Hi guys, today we will be discussing a scenario-based question on the topic of asthma in dental patients. All right, so let's just discuss what is asthma actually. And I know all of you all know what is asthma, but I want you all to remember the points which are related to the dental management of it. All right, so let's start. So whenever you have a patient with asthma, all you know right now is that you're supposed to ask the patient if he had any status asthmaticus attack in the past, or is he carrying the inhaler with him, and how often does the patient has to use the inhaler, what exacerbates the condition, right? Now, what if an asthma attack happens in the clinic? Then how are you supposed to tackle it? So first you should know and understand how would you know that the asthma attack has happened. So when the patient becomes like emotionally upset or excited, which can happen in the times of stress, and dental treatment is stressful, right? Or he gets the attack as he's exposed to an allergen which triggers it, or some respiratory attraction, infection. So, asthma is basically your respiratory tract becomes hyperactive. It kind of releases histamine and causes, those mucus accumulation. And the lungs, which is supposed to be filled with air, starts to fill with mucus. And so it's very difficult to breathe. The bronchus kind of constricts. So the pathway from where you're supposed to breathe only narrows down, and the alveoli where the gas exchange is supposed to happen, they start filling with liquid and mucus, and so breathing becomes a lot difficult. The symptoms include wheezing, dyspnea, that is, dyspnea means difficulty in breathing, coughing, chest tightness, and flushing. Now, dental management. So, when a patient comes to you, first you have to identify whether the patient is at risk of a mild attack, moderate attack, or severe attack. See, the only thing that keeps us alive, the major one, is oxygen. Even 10 minutes without oxygen and we'll be dead. So timing is very, very important here. So whenever you're having a patient with asthma, you make sure that you have an oxygen inhaler standby. So in case something happens, you can just directly start giving oxygen. So, but if you feel the patient is having an active asthma going on in a mild form, try to, get a medical opinion. Or if you feel the patient is not giving you a proper history as to when he takes medicine, how long he's been taken the medicine, consult with the medical practitioner. Always. If you are in doubt, always consult the medical practitioner. Don't put yourself at a risk. Then you're supposed to avoid certain medications. Like, remember this, take a pen and pencil and write it down. Avoid aspirin, non-steroidal anti-inflammatory, which means brufen and all, barbiturates, and narcotics because they may precipitate an asthma attack. Also, these patients are on long-term corticosteroids, so their immunity, gets pretty low. So, depending on what kind of procedure you're doing, for example, if you're doing a simple filling, you don't have to increase the dose of their steroid. But if you're doing an extraction or some major filling, or if you think the patient is anxious, then you may have to increase the dose of steroid. So read the question properly as to what level of severity the patient is having asthma or had asthma, and what kind of procedure you're doing, and what is the mental status of the patient when he tells you that I'm afraid of dentist or I'm okay with the dentist. These are all keywords to give you clues as to what is going on with the patient and how you're supposed to manage it, because there cannot be one particular answer for this question. Like, the scenarios can be various. So in one exam they can give you a severe attack patient, in another exam they can give you a patient with a mild attack requiring mild treatment. So the answers in both the scenarios would be different. I hope you're understanding this. Also, you're supposed to avoid in such patients antibiotics, macrolide ones, and you should always ask the patient to bring the medication and inhaler. This is a very good presentation, and I've uploaded this in my drive, so all my enrolled candidates can have an access to it whenever they would like, and I would suggest you do read this at least twice. Prophylactic inhalation before dental procedure is recommended, yes. Stress should be reduced, like talk to the patient, calm the patient, because stress is a trigger. Now, this last point is important and it can be asked in the exam. See, nitrous oxide is a recommended sedative in stressed asthmatic patient because it has no respiratory depression properties. So you may have a question which will say all of the following sedatives cannot be given except. So nitrous oxide is the answer. You cannot give a narcotic sedative because they are respiratory depressants. But like this point has mentioned, nitrous oxide is recommended. Or they may ask, what kind of sedative can you give in the asthmatic patient? So the answer becomes nitrous oxide. You can give. So this is an important point, exam worthy point. Remember. Then you have if oral sedatives required, you can use a low dose, short-acting benzodiazepine. That's diazepam, but don't use barbiturate as we already discussed. It's to be avoided. Now coming to local anesthesia. Now 100% if an asthma question is going to come, the sub question would be with what local anesthesia are you going to give? See, you have to understand here, the lignocaine is not a problem. Adrenaline is a problem. Why? Because to stabilize the adrenaline, they add those metabisulfites, which are preservative, and that preservative is the component which is an allergen and can trigger the asthmatic attack. Okay, so plain lignocaine is not an issue, but lignocaine special, the lignocaine special also has metabisulfite. The lignocaine with adrenaline also has metabisulfite. Wherever adrenaline will come, that's epinephrine, you will have a metabisulfite with it. So adrenaline has to be avoided. Felipressin you can give, that's an alternate to adrenaline, or some other anesthetic. You understand? So do not give local anesthesia which has epinephrine. Now, this point is also important. Asthmatic patient taking a long-term systemic steroid may require supplemental dose. See, this word may is very important. Like I mentioned, if the patient has come, say for example, a very simple filling which does not require local anesthesia, which does not require you to place a matrix band, which does not require any bleeding, it's like basically a pit and a fissure, then you don't have to increase the dose of the medication. But in case there is a deep subgingival scaling, there is an extraction, there is a root canal, or there is a bigger filling which requires matrix band placement or will take a longer appointment, and you feel the patient is a bit anxious, or he's having a high level of asthmatic attack history, then you might consider doubling the dose of the steroid so that he can cope up with the situation. And in that scenario, also, if you are in doubt, please ask the medical practitioner. So remember this point. It's not necessary that you have to increase the dose, but you may require to supplement it. Understood? Now, when an asthmatic attack happens, first see how it is. If you think it's mild, just give plain oxygen and manage it. If you think it's moderate, then again you give oxygen and you give inhalation of the steroid which the patient is carrying, okay, or salbutamol if you have that. If you think it's becoming severe, how would you know it's severe? Severe means the patient can't even talk one sentence properly. In that scenario, you will call the ambulance and continue giving the oxygen. You will never lay the patient in a supine position. Why? Because you will further increase the congestion. The patient will always be sitting upright and you will be giving oxygen via a mask. Maximum you can give is 12 doses, I guess. Don't jump to 24 direct. And that too, like you will give every 20 minutes and then a spacer and then that. So there is a proper protocol mentioned in therapeutic guidelines. Just go through that. But remember, it's a stage of asthma, mild, moderate, and severe. In a mild case, you will not call the ambulance. Understood? So you will have to see the question, what stage they are mentioning. If they say the patient has a mild asthmatic attack, fine. The options would be all of these, okay? Call ambulance, lay the patient in the supine position, make the patient sit upright, give oxygen, give salbutamol. So you'll have the same options will be present and the questions would be changed. That now the patient is having a moderate attack, what would you do? So a different option would become your answer. So read the question properly. See what keywords they are giving to point it out whether the patient is having a mild attack, moderate attack, or a severe attack. Understood? So oral manifestations, well, this just read through it for the question point of view. They might ask what you may find in a asthmatic patient. So they may have decreased salivary flow because long-term steroids do decrease the salivary flow. So yeah, that's about it. So now let's jump to the question. So read this presentation twice before answering questions related to this. I'll go on to my question on which, yeah, here. So this is the question. A 27-year-old patient has asthma and so this is her first visit, okay? A 27-year-old patient has asthma and brought her albuterol inhaler and spacer to the consultation appointment. So this is a consultation appointment. It's the first visit and she would like to have filling on her right upper canine. The patient is taking prednisolone 10 milligram for a very long time. Prednisolone is a steroid and 10 milligram is quite a dose and she's been taking for a very long time. Okay, that means she might be having immunosuppressant and for any big procedure we might have to double her dose. Now the next visit, that means you have done the consultation, you know everything about the patient and you have scheduled an appointment. So the next visit after you have administered the anesthetic agent. Now this does not mention which anesthetic agent. And you start a class 4 filling on her right upper canine. She gets an asthmatic attack during the procedure. Now this is the key word here. She was not able to speak a full sentence in one breath, meaning she is having a severe kind of attack. And she has sulfite allergy. So this last line, she has sulfite allergy, is very important, means that you definitely should not give her local anesthesia with epinephrine. Okay, because epinephrine, like I had mentioned before, requires the preservatives, metabisulfite, sodium or potassium, and it will trigger the asthmatic attack. So now let's jump onto our first sub question after knowing a brief history about how to tackle asthma. So on consultation visit, that is the first visit, while taking her medical history and listing her medications, which was prednisolone, you found that she does not have corticosteroid dosing plan. So basically the patient does mention that she's been taking prednisolone, but she doesn't know how many times she takes or when she's required to take more or less. So in that scenario, what would you do? Whenever in doubt, always consult the medical practitioner. Now, when you would consult, so what are the options here? Increase steroid on the next visit. That's true, but then you haven't consulted the medical practitioner, so better ask him if that is the option available. If that option wasn't available, I might have gone with the option A. Second option, consult a medical practitioner, great, to increase the dose one day before the procedure. No, we have always been taught it's on the day of the procedure. So one day before is not correct. The option C is on the day of the procedure is correct and it includes medical practitioner as well. And D option, steroid dose does not need to be changed. Now because she's taking since such a long-term steroid, as the question has mentioned, they would require to increase the dose and it's a class 4 filling, meaning you have to place the matrix band and it's going to take some long time, correct? So I would go with option C, though option A was plausible if option C wasn't available. Now which LA can you use with the patient? Lignocaine special. Special has potassium metabisulfite and epinephrine. Plain lignocaine is the one which does not have it. Articaine with adrenaline. Adrenaline we don't have to give it all, okay? So any question with adrenaline, just mark it wrong. Septanest without adrenaline. Yes, this is a good option. Mepivacaine without adrenaline plus double dose of steroid. See, the question is very specific. Which alley can you use? So even if I'm confused between option D and E, this is a more safer option. So I would go with that because it does not say double the dose of steroid. My question is not asking me I should double the dose of steroid or not. My question is just asking which LA can you give and I have a simple option here. I would go with that. If this was not the option, then probably I would have thought about this. Okay. Now we come to On procedure day, she developed asthmatic attack in the dental chair and she was not able to speak a full sentence in one breath, meaning she's having a severe attack. So how would you manage? Lie her supine. The moment you read this, just forget reading the other part of the same option because you should never lie the patient in supine. Set her upright. Okay. Give 4 puffs of corticosteroid inhaler. Sounds good. Lie her supine. Again, I'm going to mark this wrong. Set her upright and give 12 puffs of short-acting bronchodilator inhaler via a spacer. This also kind of seems right. Do I have a better option but? Call 000, sit her upright, give oxygen and 12 puffs of short-acting bronchodilator. Now you see all these options can be the same and I can just change this question. I can say she had a mild attack. In which scenario my option B would be right? I say she had a moderate attack. In which scenario my option D would be right? But when I say she is having a severe attack, then my only option E is correct because I have to call the ambulance here because it's a severe attack. Understood? So read the question properly. It may happen that in the past exam this question came and in your exam the same options will come but a different question would come like I just mentioned. Understood? So you cannot mug up. You need to know the concept and that's why I took a presentation and explained you that. Read that presentation again. Understood? Next. I've also given a feedback. Go through it. If a spacer was not available, what to do? Read more about spacer. See, spacer is basically what you give an inhaler. Like, for example, you give a puff of salbutamol. There is a way the patient has to breathe. Like, they will have to take 4 breaths, then take inhaler, then take 4 plain breaths. That plain breath is a spacer, basically. And there is a kind of a device which comes. So do one thing, Google a little more about the spacer. But anyways, even if you can't find, just remember this as a theory. If a spacer is not available, then you are supposed to give 5 milligram by nebulizer driven by oxygen. 5 milligram of the inhaler that the patient is carrying. It can be albuterol, salbutamol, whatever. It's 5 milligrams and not 10 milligrams. So read more about what is spacer. That is a little more theory which you can read. You can find something on the Google and you can read also. Now, if the patient starts to be less conscious, what to do? Prednisolone is an oral medicine. You can't feed the patient. 24 puffs of short-acting bronchodilator inhaler via spaces. 24 puffs is a lot. The max you can give is, I think, 12 to 16. So 24 puffs becomes a lot. So you will be like, give salbutamol continuously till support arrives. So you may have 2-3 other options with this. These are the options that we remembered. But usually if the patient starts to be less conscious, that means the patient is feeling drowsy, you tend to avoid the spacer because you want continuous bronchodilation to happen. Spacer meaning there is a period where the bronchodilator is not being given. Okay. So if the patient is becoming less conscious, that is basically drowsy, then you continuously keep on giving salbutamol. So you can remember this question in this way also. So there it is. I finished one scenario-based question on asthma. Read more about it. You may have, medical emergency questions will always come in your exam. Be it diabetes, be it CPR, syncope, asthma. So these you should know. And these questions can also be asked in your OSCEs in part 2. And it may also come as a station out there, in your this thing. Skilled OSCE. You can have a CPR syncope. They can also add asthma to it. Anything they can do. So medical emergencies, you should know. So today I've done about asthma. In future I would do with other medical injury, conditions. I would explain that like in the form of presentation. I will upload that in my drive so that you can have access. And then solve a question related to it so you have a better understanding. Alright, have a nice day. Bye bye.